Okay, I switch gears here now. Remember, you have to hold your questions till the end of this panel. And I want to introduce Dr. Nirav Shah, who is going to introduce the rest of the panel. He is a senior scholar at Stanford University's Clinical Excellence Research Center, which means I see him a lot, because that's co-located with the Center for Advanced Study in Behavioral Sciences up on a beautiful hill. And he's an elected member of the National Academy of Medicine, about which we've heard. He was previously commissioner of the New York State Department of Health, and then senior vice president and chief operating officer for clinical operations for Kaiser Permanente in Southern California. So he's had a lot of different kinds of experiences. He engages in path-breaking research, as we heard Mark Cullen referred to one of his studies already, but particularly on patient safety and quality, innovation, and digital health, and the strategies required to transition to lower-cost, patient-centered healthcare. Nirav. Virginia and I will join you afterwards, I think. Shall we join? Yeah, we'll join you after your panel is finished.
I thought I was going to get a copy of your book. Just kidding.
They're available.
Thank you. Well, I'll have to buy one then. It's really my pleasure to introduce my panel and just give everyone just a 1-minute primer on public health. I think we heard a very nice description from Margaret of what public health was defined 1,000 years ago in Siena. But I prefer a 1920 definition from one of the greats of public health, C.E.A. Winslow, who defines public health as the science and art of preventing disease, prolonging life, and promoting human health through organized efforts and informed choices of society, organizations public and private, communities, and individuals. And most of you know about public health. When it fails, you know about Flint and what happened with the water. You know about Hurricane Sandy and what happened in New Orleans. So it's kind of the silent, when you don't know about it, that's public health, and we only hear about the bad things. But you'll hear some good things today, too, about what are the opportunities. And I hope you understand what you take away is that there is real need for all of your collective thinking, our collective thinking, around how do we approach public health in the new age that we're entering. I'm really pleased that we have 3 fantastic panelists today to describe some of their work and some others' work around AI, machine learning, and public health. Our first speaker is John Auerbach, who is the president and CEO of the Trust for America's Health, which is a nonprofit, nonpartisan organization dedicated to saving lives by protecting the health of every community and working to make disease prevention a national priority. He's also one of the most thoughtful and powerful voices in public health in America. Chad Heilig is the Associate Director for Data Science at the CDC. And although he did get his PhD from UC Berkeley, we're still happy to have him here today. And finally, our final speaker will be David Buckeridge, who's a professor of epidemiology and biostatistics at McGill University in Montreal, one of the leaders in AI for Canada, actually. And we're proud to note that he's one of our own with a PhD in biomedical informatics from Stanford University. John, please begin. Thank you. Thanks.
Thank you, Nirav, and good afternoon, everyone. I would start by saying that I've spent most of my career as a public health practitioner. I was a city health commissioner in Boston for almost a decade. I was a state health commissioner in Massachusetts for about 6 years, and then I worked at the Centers for Disease Control overseeing policy for Dr. Tom Frieden. And most of those years that I spent as a public health official, I was involved in doing an assessment and response to a variety of different health risks that potentially would affect the health of the public. Most of my work has been consistent with what Nirav just said, looking at preventing a bad thing from happening, and by understanding what the risks were, identifying those who are at disproportionate likelihood of being at greatest risk, and intervening in order to avoid a bad outcome. And today what I'm going to do is share with you two examples that illustrate the way that public health is involved in looking at complicated data and considering the potential use of artificial intelligence. The first one involves responding to the danger of food poisoning from food establishments. And across the nation, and especially in most cities with a variety of thriving food establishments, food poisoning is not uncommon. CDC, for instance, estimates that 48 million people a year have food poisoning. 120,000 of those people are hospitalized, and 3,000 of them actually die. So public health has a major role in terms of trying to prevent food poisoning, and one way that we're involved in that is we do the inspections of food establishments to try to ensure that safe conditions are being followed, working on appropriate hygiene, refrigeration, et cetera. But what is the case in the United States is that the number of food establishments far exceeds the workforce in public health that is intended to provide those safeguards. For example, when I was the Boston Health Commissioner, my staff only visited restaurants in the city of Boston maybe once every 3 years. So there wasn't a close oversight of what those establishments were doing. So I'm going to share with you the experience from Chicago. In Chicago, there are 15,000 food establishments, but the health department only has about 36 inspectors who are responsible for ensuring that all 15,000 of those are operating safely. And they were recognizing in the Department of Public Health that that was a problem, and that they needed to have the best possible approach to understanding how they could control the quality and protect the public. So the Department of Public Health worked with the city's newly developed Department of Innovation and Technology, and they analyzed past violations. They started by interviewing all of the inspectors. They looked at a variety of different variables, including ones that had never been incorporated into any kind of a risk assessment. And from that, they developed a risk algorithm, one that was based upon past data, drawing in information from a variety of different non-health sectors to help to make a prediction about which health establishments might be at disproportionate risk for violations. They looked, for example, to such things as 3-day average temperature, the proximity of establishments to garbage-related complaints or to burglaries. They looked at whether the establishment sold tobacco or alcohol. They looked at the length of time the businesses had been in operation, together with past information about violations. And then they put the algorithm in place, and it guided what establishments were prioritized in terms of inspections. Ultimately, they all were inspected, so this was just an ordering of the inspections so that those that were considered from the algorithm to be at greatest risk were visited first. And then they evaluated it, and what they found was that by following this method, they were actually able to identify those establishments in violation 7 days earlier than they otherwise would be in the other method. Ultimately, everyone was visited, so there wasn't a discrimination in terms of visiting some but not visiting others, but they ordered the timetable for when they would be visited based upon this. And as a result of that, that type of assessment prevented people from getting food poisoning. The formula that they developed was done in a manner that allowed it to continue to improve over time as new information became available about the variables that might suggest which places were at greater risk, and so it's continuing to be strengthened based upon the approach that they've taken. The second approach, the second example that I'll be giving you, involves one of the worst outbreaks of HIV in the nation. This took place in 2015 in a relatively small rural county in Indiana called Scott County. Scott County has about 4,400 people in it, and by the end of the time this outbreak was over, more than 200 people were identified with HIV. That's about 5% of the county population. And shockingly, most of those people were infected within a relatively short period of time, about a 2-year period. The outbreak was particularly instructive in understanding the intersection between the epidemics, if you will, of opioid use, of the use of injection clean needles, and of infectious diseases like not only HIV, but also hepatitis and other sexually transmitted diseases. And part of the response to that outbreak was the rapid involvement of state public health officials, including the state health commissioner at that time, Jerome Adams, who is now the U.S. Surgeon General, as well as officials at CDC. I was at CDC at that time. And folks went in and they responded by screening the population, by linking people up to drug treatment and HIV counseling, and by bringing services into the county that hadn't been there before. But what they also understood through doing the interviews with the people who lived in the counties, that there were other risk factors that went beyond the access to health care or the elevated risk of opioid use that had to do with such things as unemployment, the number of people who were finishing high school, the sense of despair within the county. There were, in fact, people who said, when offered the services, what's the point? What's the point of getting services for HIV? You know, we're going to die early anyway. So there was a recognition that addressing the social determinants of health, being sensitive to those, was critically important in terms of the response. And the interventions were effective. Policy was changed at the state level. The governor, after opposing it, agreed to support needle exchange, for example. And public officials at CDC at the end of the outbreak wondered, would it be possible to predict other counties in the United States that had similar characteristics and might be considered a disproportionate risk for a similar type of outbreak? So working with partners, CDC developed a multi-step analysis to identify what appeared to be the indicator variables that might suggest risk in other counties around the country. And these included looking at some of the health-related indicators I've mentioned, like prescription opioid and other drug sales, overdose deaths, but it also included socioeconomic information such as per capita income, unemployment, and it included race and ethnicity data. Using that analysis, the Centers for Disease Control was able to identify 220 counties within the country in a wide variety of states, including Ohio, Pennsylvania, West Virginia, Kentucky, and Tennessee, that seemed to be at elevated risk in the same way that Scott County had been. This information from CDC was then shared with the public health officials and other officials within those counties, along with support, technical assistance, and information and guidance on what would be the lessons from Scott County and particular approaches that might prove effective in terms of reducing the risk in those counties. It was very difficult to evaluate this because, you know, as we have both said, when nothing happens, then public health has succeeded. So it's very possible that the awareness within those counties that there was elevated risk did result in targeted interventions and maybe even policy changes that reduced the risk. It is worth noting that in terms of the experience of those 220 counties, none of them had a similar outbreak to Scott County. So it's possible that sharing the information had a beneficial impact. So these two examples, the one from Chicago and the one from Scott County, are similar attempts to to combine data from a variety of both health and non-health sources to project elevated risk and to guide interventions to try to prevent risk to the public. More could be done with such examples if they were combined with machine thinking on an ongoing basis that allowed for continually adding new information to make the predictions more precise, and also to ideally assess whether the interventions that were offered to accompany the risk were successful and whether they could be improved as well. Thanks.
I'm also going to share two examples of the use of machine learning in public health applications at the Centers for Disease Control and Prevention. I'm going to focus on two that are specific to making better use of meaning from text, and also maybe give a bit of a pointer to other places that CDC is looking at using machine learning applications. The first is for monitoring autism spectrum disorder in children. Every 2 years, the CDC coordinates a network of sites to gather evaluations about 8-year-old children. These evaluations are accumulated over their encounters with educational and clinical and other settings, and so these evaluations might contain anywhere from a few hundred to a few thousand words. A few years ago, one of my colleagues, Matt Maynor, at the CDC, showed as a sort of a proof of concept that he could train a machine model, random forest specifically, on the text of evaluations from one site's data from 1 year, and then to predict which children meet the surveillance case definition in the following round. And he achieved 87% accuracy, where the agreement between experts is 91%. And so this actually fairly naive structure of a model performed remarkably well. The main advantage potentially is that we have a very labor-intensive process where typically these evaluations are reviewed by experts on the order of, across all of the sites, 10 to 15,000 every 2 years. And a trained model might be able to help to do that part of the workflow more quickly and either therefore expand what we can do, the reach of the monitoring program, or allocate scarce resources more efficiently. Another example is using emergency department records. This is a contrasting example in a few ways. One is that when a person shows up at an emergency department, one of the first pieces of information that might be available is their chief complaint, which is going to be a few characters to perhaps a few hundred characters. So there the size of the message is already different, but the scale is different as well. There are millions of emergency department encounters each day in the United States, and networks of using this information regularly for local and state level practice. In this case, a couple of different machine learned models will help to, on the one hand, group together conceptually similar chief complaints. There are certain practices currently that group chief complaints based on matching strings, substrings, not even quite as complicated as regular expressions. And using machine learned models might be able to help us develop conceptual groupings that would improve our ability to find patterns in the data. And secondly is a model that might use the content of the chief complaint to extract more meaning and be able to, in some cases, anticipate what the discharge diagnosis is going to be, and therefore gain a bit of lead time in the application of these data for public health practice. Earlier today, Professor Chen told us that the penetration of machine learning into medicine lags about 10 years. The penetration of medicine lags a bit further into public health practice. And so CDC is exploring a few of these applications, also the use of computer vision for identifying sidewalks in built environments, the use of computer vision for microscopy and radiography, the use of other semantic methods for social media feeds, and so on. But in the practice of public health, our ability to use these tools is still limited by a little bit by our imagination, but also by our access to the methods themselves. And then, most importantly, making methods that are shown to be useful available to state and local practice.
So as we're getting a little closer to lunch, I hope you'll be happy to know I've limited myself to one example. But before I go there, I want to back up to a bit of the big picture, which I think, in terms of public health, which I think others have kind of laid out nicely, including Victor Zhao in his talk. But I want to really think of a number, and this number is the percent of all disability and premature death in the United States that's attributable to chronic disease. Just what percent you think that is? You think about it for a sec. I won't take a poll. It's 85%, according to the Institute for Health Metrics and Evaluation in 2016. And the two most responsible risk factors for that are unhealthy diet and increased body mass index, or obesity, from another perspective. But despite the profound importance of these factors, essentially what people eat, their diet, it remains incredibly difficult to measure what people eat and even harder to influence what they eat. And so one kind of exciting opportunity here, which is a little bit outside the traditional public health, formal public health infrastructure, if you will, but we think is interesting, is the use of digital grocery transaction records to better measure and possibly influence what people eat. And so these are the records that are generated every time a purchase is made, and there's a scan, and you hear the little beep. That data goes into a database. And those data can be accessed through different means. One means is through resellers who will sell you a bunch of store-level transaction data. And that's somewhat useful for measuring what people eat at population scale. But even more interesting are partnerships with retailers, so large grocery chains, who can also make available those data for measuring, but then through partnerships, you have the potential to think about influencing at the point of purchasing in other ways what people might eat. So how does that happen? Well, when these data are aggregated across many different shoppers or retailers, they're sufficiently large to fit or estimate high-dimensional predictive models. And of particular interest are loyalty card holders or affinity card holders. So people who have a card that tags their purchases from purchase event to purchase event, because that allows those purchase data around all the things they're purchasing from food to be linked longitudinally. And then you can start to think about responses to stimuli. And so response in this case is purchasing different types of food, which may be healthy or unhealthy. And stimuli, of course, are different marketing strategies which are used routinely. Things like coupons, discounts, providing recipes with those ingredients, all sorts of things. Also of interest, because usually when you access these kinds of data, for privacy reasons, you might get the loyalty card scrambled identifier and some kind of rough geographic linkage or relatively geographic linkage, but no other information. However, you can also usually recover some information about those loyalty card holders by linkage to data like census geographically at a neighborhood level. And also marketing firms have shown quite clearly by analyzing basket contents people buy over time, you can also make very good inference about household dynamics or structure. So what's interesting then from a kind of a statistical AI perspective is that you can fit these predictive models, if you will, to these data, particularly for loyalty card members who are frequent shoppers and can be shown to be doing almost all of their purchasing at one particular chain. And then you can create models where you would try to nudge people to make healthier choices. So if you think about Netflix, when you go on and try and pick something to watch, they say, well, people like you have picked this movie. So you could say, well, people like you, who we know, presumably you could do this with somebody's consent, not anonymously, obviously. You sign up for a service, and you could say, people like you that are trying to reduce their blood pressure or trying to reduce weight would probably pick this instead of the thing you usually purchase, and we think you'll like it, and it should make you healthier. And if such a system can be put in place or arranged so it's also either net zero or positive in terms of profits for the retailer and improves the health of the patient or the consumer in this case, then you have kind of a win-win situation in theory. So back to the equity and inclusiveness piece. So what's the potential challenges with this kind of interesting, innovative strategy? At least I think it's interesting. Well, the first is, who's this intervention going to reach? So, where do you actually build these models and train them? What kind of retailer, for example, is going to work with you? And what kind of people are shopping at that store? And of those people who are using loyalty cards and shopping frequently at that store. And so you can see that we're getting an increasingly somewhat distorted, if you will, data set here. And then presumably you could fit such a model, and if you're going to make it commercially viable, you'd have to go and use it in other retailers as well. Well, how well would it really work in different retailers that have different populations of consumers shopping there? We don't know. The challenge, of course, is to build these kinds of tools requires trust between a retailer and a researcher or a public health group, and that is built over time. And it's very difficult to think about how you'd take that now to a different retailer and start fitting it to their data, proprietary issues and so on. So just to say, the solution I think we all know for these kinds of learning problems where you have kind of a biased data set and you'd like to be more generalizable to others is quite clear. You get generalizable data. But I think this example just demonstrates in practice, here's a technology that we think could be interesting, but it's very difficult to think about how you make it generalizable, both in terms of targeting many people, and ultimately as we think about also who would ultimately go into those kinds of stores and use loyalty cards and so on, that's a rather select population. And so you worry in the big scheme of things, are you making that population healthier and leaving behind other parts of the population? Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.